Welcome to the Peds Hub Pod, an educational podcast created by paediatric trainees in the Southwest.
Featuring reviews of journal articles and interviews with authors and specialists.
Please note, these are our own opinions and do not substitute professional medical advice.
Thanks for listening.
Hello and welcome to another episode of the Peds Hub Pod. My name is Leila Ellis and I am a paediatric trainee based in the Southwest, and I'm very excited to be joined today by a colleague and friend, Nicola O'Donnell, who is a doctoral researcher and health psychologist based with the University of York. Welcome, Nicola. Thank you so much for joining us today. We're at the CCLG Children's Cancer and Leukemia Group Annual Conference, and we are going to be talking about some of the late effects of childhood cancer. So thank you, as I say, for joining us. Perhaps you could tell us a little bit more about your journey to get to where you are before we delve into some more of the detail.
Thank you for having me. It's really nice to be asked to come and speak to people down in the Southwest. I always struggle with how to explain what I do because it feels like it's in so many parts, but essentially part of my time is finishing my PhD at the University of York, where I am specifically looking at psychosocial support for childhood survivors of retinoblastoma, the eye cancer. But I also work clinically as a health psychologist, not exclusively in oncology, although that is my area of interest, but also I've worked in various settings within paediatrics like eating disorders services, general mental health, and lots of other different things. So
a wealth of experience that we are able to tap into today. I am really interested in your PhD work, and I wonder if you would be happy to tell us a little bit more about how the project was developed, a little bit about the amazing work that you've done in that, and I guess any lessons that you have drawn or things that you could share, particularly for those who are working with young people in terms of whether it's oncology or other health conditions.
So like I say, I'm 2.5 years in, so 6 months to go, and the aim of my PhD is to generate the evidence for the development of a new psychosocial intervention specifically for survivors of retinoblastoma, or RB as it's commonly referred to. And the ultimate goal post-PhD will be actually to develop an intervention, because there just isn't anything routinely used out there for this group. So RB is only diagnosed in approximately 50 children a year in the UK, and within that there's a couple of different types of the condition that you can have. One is heritable and the other isn't. So as you can imagine, that brings a whole new complexity to a diagnosis. It's often diagnosed in babies and very young children. Rarely is it diagnosed above the age of 6. And thankfully there's a sort of 98% survival rate in Western society, where we've got access to great treatments. But what we do know is that whilst the medical care is amazing, the psychological impacts of surviving not only cancer but a rare cancer that has its own complexities and unique aspects to it can leave young people feeling a whole host of different psychological impact from their diagnosis and treatment, even if it was 10, 15 years prior to now.
So you mentioned in terms of kind of that age range around diagnosis, so most are below 6 years old and very rarely above, and then the psychological impact of that developing over that young person's childhood and into their adolescent years as well, which is a really significant time for anyone. So perhaps delving into some of those impacts that have come up through your research in clinic and through speaking with people, what are some of the key impacts that arise?
Yeah, and like you say, I think childhood cancer generally has various different impacts on people that differ depending on when they were diagnosed, what their prognosis is, the long-term effects that they might have from their diagnosis or their treatment. But for RB specifically, what we found in our research is that, firstly, a lot of the young people that I've spoken to do have a lot of memories of their treatment, even though sometimes they were 1 year old, 2 years old. And that's really difficult for them because there's a lot of expectation from people around them that they won't have any recollection of it. Therefore, they shouldn't feel bad about it. It's something that happened, they've survived it, and move on with your life. But we know that it's not that simple for everybody.
Yeah.
So we found there was a lot of, firstly, survivor guilt, because there is thankfully such high survival that this group of young people didn't feel like they quite fit in with other childhood cancer survivors. One, because sometimes the treatment is relatively straightforward, not pleasant, but sometimes includes removal of their eye, no necessarily chemotherapy, radiotherapy, anything like that. So although they've got a lasting impact in terms of their appearance and how they look, a lot of people tell me that they don't feel like they fit in with young people who had lots of chemotherapy or lost their hair. So there's lots of survivor guilt, there's a lot of anxiety about talking to their parents about their experiences. Which was really interesting because a lot of young people said to me, well, my mum, my dad, they remember every minute of it. They were there, I was a baby. They'll remember every blood test, every treatment. And people don't think that I do. And whilst they may not remember in the same way, they often express feeling bad for bringing it up, or not even having the language to say to their parent or their doctor, whoever it is, I feel really worried or really sad about what happened to me. And I guess that was the other point, that a lot of the now teenagers and young adults didn't have the information about their condition because it was given to their parents such a long time ago.
And that's a key, I mean, there's so many key points that you just mentioned, but the idea that someone might remember their treatment and that experience from such a long time ago, and that's relevant to all these young people that we're seeing every day in clinical settings. The fact that the communication at that time might have been directed at parents, not necessarily age appropriate for them, but also how does their information needs and wants change as they get older, because they still remember this experience, they remember that from their personal perspective, from the experience that their parents went through, and then having those conversations in the language. And I imagine there's probably quite a degree of variation, you know, everyone's going to want different things.
Different things at different times as well. So I think it's really hard to put a time frame or an age limit around when do we have conversations, because you might have a 10-year-old who's really mature, emotionally aware, and wants to have those conversations, and then simultaneously you might have an 18-year-old who doesn't want to, can't do that. So I think one of the challenges is, when do you have those conversations, especially when you're not being seen by your team anymore because you were treated and successfully in remission a long time ago. It's really, really challenging. And actually, just going back to the memories point, what we found, which I think is quite a novel finding, is that the memories that a lot of these children have are quite sensory. So we know that when people experience trauma when they're very young, they're not remembering things in the sort of way that you and I might as adults, and often it's stored within the body, within the senses. And what was really fascinating was a lot of the young people I spoke to said that these memories are often quite dormant, and then something will come out of the blue and sort of take them back to that. So one of the examples in my mind at the moment is Sharpies, like the pens. Someone was saying they've got a really distinct smell, and that, with no warning, took them straight back to having anaesthetic and brought up a whole load of really complicated emotions. So quite challenging in that these things often happen when people don't expect them to, and if you haven't got the language around even how you feel about it, let alone telling someone else, you can imagine it is really difficult to manage for these young people. And I think it's really good to have these conversations, but also to acknowledge that it is really hard both for clinicians and young people to even start these conversations, because, don't get me wrong, not everybody I spoke to had really hugely traumatic memories. Some people had memories of particularly kind interactions they had with their medical team, or a lot of people have quite neutral memories, like yeah, it happened, don't really think about it now.
Right.
But a lot of people did have difficult experiences that they didn't know how to bring up, and as a clinician I think it's hard to have the time to have those conversations, what to say. I think people worry about bringing things up and almost triggering emotional responses from young people.
Right.
But equally, we know that teenagers often find it's the hardest time in life to express you need help and to accept it as well. So it's a bit of a difficult situation for everybody to try and manage and have those conversations in a helpful way.
And what are some of the tools or approaches that you take from the lessons that you've learned through your research into the clinic?
The thing to always reiterate is that everyone's individual, everyone's going to have different wants and needs and abilities to discuss how they're feeling. Some people cannot think of anything worse than sitting down in a room with a psychologist, which is where other professionals can be much less intimidating, I think, than, you know, you say the word psychologist to some people and they're like, no.
There's a sort of perception of what that's going to look like.
Yeah, and how it's portrayed in like films and TV is just someone sat in a chair being like, how do you feel about that? When we know that that's not always how it works. And so going with the individual, seeing what they already know and what they want to know, finding out what's important to them. I think with young people especially, it's important to get their views, because often they're quite surprising in that what they want to talk about or want to work on is perhaps not something you'd considered, or what their parents think they would like to talk about. So firstly, leaving any sort of preconceptions at the door and going with what they think. Then trying to work with them in a way that fits them. So I think there's a lot of really nice tools that can be taken from approaches like acceptance and commitment therapy, which is a way of working with people therapeutically, but it's got quite a lot of helpful conversation starters, at least for people who may not have psychological training specifically. Another approach that some people might be aware of is compassion focused therapy as well. So I think adding therapy on the end makes it sound very formal and like you need a lot of training. And whilst I wouldn't say for people who aren't trained to offer therapy, I think there's a lot of techniques and just reading around those approaches that can be really helpful in guiding discussions with young people clinically.
That's really helpful, Nicola. Are there any resources for either of those approaches that you would direct people to?
So there's lots of resources that healthcare professionals, whether you're doctor, nurse, physio, whatever profession you are within paediatrics and paediatric oncology, I will make sure we have those resources in the show notes of the podcast.
That's amazing. Thanks so much, Nicola. So Nicola, you very eloquently described some of the conversations that you've had with young people about the challenges they've had, particularly related to retinoblastoma. I wonder if you could share with us as well some of the other impacts from different types of childhood cancer that young people have expressed.
Yeah, and we know from both the research that's out there and clinical practice that both when someone is undergoing treatment but also afterwards in their survivorship journey, that they can have quite a lot of differing psychological and social impacts. So those range from emotional distress, so we know that quite a lot of childhood cancer survivors experience some sort of anxiety, low mood or depression, and the trauma that comes with cancer diagnosis and treatment can lead on to more ongoing psychological struggles, understandably. Equally, we know that children and young people who have undergone treatment and may have been out of school or their peer group for a long time, or in and out, not being able to go about their everyday lives like their peers, experience a degree of social isolation, and that can be perpetuated even more if they have body image concerns or body image changes, so physical changes due to treatment like scarring, hair loss, limb removal, whatever it is, we know that any change to our appearance can lower self-esteem, particularly in adolescence, when for just the average teenager with no health concerns, that is a time when you need to work out who you are, what you want, what you look like. It all becomes very heightened. So adding on any changes to that can be really challenging for people. And then I suppose lastly, there's cognitive impacts as well. So some survivors experience late effects, so difficulties with their memory, with attention, their learning. And again, if you're combining that with being in and out of school, that can make people feel that they're not doing like what they should be doing, they're not doing as well as their friends, and that can all be hugely difficult to manage emotionally. So, I mean, there's other things as well, but I suppose those are some key psychosocial impacts that a lot of childhood cancer survivors experience.
The follow-on question from that is, what can we do? So my understanding is that there are different offers of follow-up clinics and late effects clinics and support for young people to transition from the children's services to the adult services, but actually that can look quite different in different places in the country. I'm curious to hear perhaps a little bit more about what support is available.
And I think the key thing is what you just said, that it does vary so much from place to place, and unfortunately many services either don't have psychological support specifically at all, or it's shared amongst lots and lots of departments, so there's not enough input to go around. In an ideal world, in line with the NHS long-term plan, is that we should be providing personalised care to everyone who needs it, and again, for those that want and need it, includes some sort of psychoeducation or psychosocial intervention. And what those terms mean, because I know people are often like, what is that? It is essentially therapeutically providing individuals with relevant and up-to-date information about their health in order to support them to live with or beyond their diagnosis. And that can involve loads of different things, but some quite common ones are peer support and discussion, drawing on the evidence base to offer problem solving and coping skills. And now, since COVID and with the development of technology, quite a lot of app-based and technological interventions as well. So there's a lot that is out there and can be really helpful, but I think in reality it's often a struggle to access that or to have the resources to provide that. You're going to get families and young people who think, I've got through my treatment, I want to just go back to sort of quote normality. And you're going to have people who want psychological support throughout and afterwards, and then some that will probably go back to their life beyond cancer and then suddenly feel a need to access some support much later on. So it's hard to know when people are going to want support, and therefore how to structure it and what to offer.
And we've spoken before about this concept, and it's been quoted in the literature, of being in limbo after treatment ends, and there's a period where you are well supported and surrounded by a team, whether you're undergoing intensive treatment, and then thankfully there's a period where that shifts and your life looks different, and the quote-unquote normality, or what that is for you and the support that you have, this concept of limbo feels really hard to accept. It's another important reason that we are investing in these resources. And again, the interventions that hopefully we'll come on to talk about in a little while, and the different ways in which they can be accessed, just being aware of that and being able to point people in those directions at different points in their journey feels like something that we could be doing now.
Absolutely. And I was just reminding myself as you were speaking that I read in a paper recently that adolescents and young adults have been referred to as a sort of lost tribe in supportive cancer care. And I think particularly, I know we're talking about children all the way through to adolescence and young adulthood, but I think those that are adolescents and young adults often don't fit neatly into either child or adult
Exactly,
services.
exactly.
And it's just really tricky because it's a very unique time of life for any teenager or young person with lots of transitions, and therefore it needs to be tailored quite specifically to that time in people's lives.
Nicola, I wanted to ask you a little bit more about the different psychosocial interventions that have been developed and are on offer, and different accessibilities that we've briefly started to speak about. But I wonder if you could talk us through what the landscape currently looks like for psychosocial interventions, particularly for children who have gone through cancer treatment and perhaps entering that survivorship period.
Yeah, and I want to start by saying that this is all in an ideal world, because with the best will in the world, a lot of services either don't have access to the interventions that would be in the evidence base as the most effective for this group of young people, or don't have the resources to offer anything at all.
Right.
So in an ideal world, there would be a full range of psychological interventions on offer to people. It can be helpful to think about these interventions in broad categories. So, as I mentioned earlier, there's a move towards technological and app-based support, which is great because it allows accessibility in a way that maybe wasn't around pre-COVID, pre-pandemic. That's definitely sped things up, but equally has its own challenges in that, you know, some people don't have the internet access that is required, or, you know, these things often require you to have a relatively up-to-date smartphone or laptop. And again, whilst many of us take for granted that these are things that lots of us have, that can actually exclude people who maybe don't have access to these things. So of course we need to have the other options available. So aside from app-based technological support, there's the more structured training programs, which sounds quite formal, but it often focuses around offering some sort of coping skills training to young people and or their family. So there's things like physical exercise training or music therapy inspired interventions. There's lots of really good things out there, and lots of support that taps into different parts of our well-being, whether that is moving more, eating more healthily, or specifically focusing on emotions, which leads into another category, which is more formal therapeutic support. So that would be delivered by a psychologist or a specific trained therapist, like a cognitive behaviour therapist, for example. And these programs often involve some sort of psychoeducation, so giving people the information they need about their cancer, their maybe any long-term effects from their diagnosis and treatment, and things to be aware of, but also offering them therapeutic support. So whether that is just talking, which can be incredibly powerful in itself, or doing more structured interventions. So that might be focused around anxiety, for example, or low mood, or whatever it is that that young person is particularly struggling with. Yeah, hopefully that's a bit of an overview.
Yeah, no, that's a really useful overview. I'm curious to explore a little bit more about how do we match the person with the therapy, and I imagine preferences will change over time, and depending on where someone is in their personal journey, your needs and wants will be different. But how do we know what works, and what's the evidence? How do we choose what gets funded? All those big questions.
Sure, and I think the important thing that you said there is about knowing what works. So of course it's really important that any support that we offer people is scientifically tested, is evidence-based. And of course you and I have just completed a systematic review which aimed to look at the types of psychosocial intervention that have been trialled for teenagers and young adult survivors of childhood cancer, and that was any kind of childhood cancer. We weren't keeping it specific to any particular group. And we also looked at whether any specific type of intervention or intervention category was more effective in improving mental well-being of survivors generally. And then just on the flip side of that, seeing if any interventions were found to have any possible negative impacts or adverse events on people's well-being. So we've got these questions, we've got these aims. But how do you go about narrowing down all of the information out there to find the papers that are specific to what we wanted to know? So after coming up with our protocol and doing some searching of various different databases, we were faced with the nearly 8,500 articles, which is obviously a huge amount of data, of which key terms are picked up from the search terms that we used. So at that point we needed to screen each article according to some criteria that we had to make sure that the papers that we included in our review were actually looking at teenagers and young adults, were offering psychosocial support rather than a medical intervention, for example, and to be clear that the groups of people that were included in the studies were not still in active treatment for their cancer, weren't under palliative care, but had actually all been in remission from their cancer and had accessed some sort of psychosocial support. So after looking at all those papers and critically appraising their relevance, we ended up with 15 papers and therefore 15 psychosocial interventions with just over 1,000 post-treatment survivors of childhood cancer. So
those 15 studies were across multiple countries looking at multiple interventions. So this is, I think, the key learning for both of us was the idea that actually there's such a huge degree of heterogeneity within the literature, which kind of reflects, I guess, how we got into this conversation initially, that there's so many different options available. And when you're asking the question of what works and what is relevant, I think our first conclusion was that it's quite hard to say because, there's so many different tools available. So that led us to think about the different outcome measures.
Yeah, because I suppose one of the struggles that we had within this review was that very few of the studies, even though there was only 15 of them, very few of them used the same outcome measures. So it was very difficult, therefore, to compare how effective they were because they were measuring completely different things. And like you say, because of the heterogeneity of that data, it was tricky to draw nice, firm conclusions about what works and what doesn't for childhood cancer survivors as a whole, because we know, of course, that different cancers affect people differently. What age you were diagnosed is going to change your relationship with that and how it's impacted you, amongst loads of other things. We are suggesting that there isn't enough routine psychological support that's offered to young survivors. And that's not to say that there isn't lots of great things going on in discrete teams in different clinics, but often the interventions that are being conducted in that way aren't tested. And I suppose in the systematic review I should have mentioned that we were only looking at interventions that had been tested with randomised controlled trials, and therefore we didn't collect data on what I'm sure is a lot of the amazing interventions that are being offered by individual teams. You mentioned we're at the CCLG conference today. I've heard about 2 examples of that today, but those weren't captured in our review, and therefore it makes it really hard to know if there is something really great going on, because sometimes it's just not researched for its effectiveness in standardised way.
So even though there was a lot of heterogeneity and a lot of differences in the outcomes that were measured, and whether that was the scale that was used or the time frame or the frequency in which the intervention was delivered, and all the different factors that went into the published evidence of what works, we were able to pull together some conclusions, some lessons for this early stage of the work.
It will probably sound really broad, but essentially the good news was that we found that a lot of these interventions had both short and long-term effectiveness in various factors in people's lives, like their quality of life, their anxiety levels, their coping, etc. And ultimately we concluded what we probably already know, is that a multifaceted, individualised approaches are needed to consider the specific needs of teenage and young adult cancer survivors. And actually we need to work to establish more set guidelines for professionals to support the integration of comprehensive survivorship care from a psychosocial perspective alongside the medical intervention at all stages of someone's cancer journey, so from diagnosis through their treatment and beyond.
So we've briefly spoken about the evidence that's available around psychosocial interventions. We've spoken about some of the great work that you're doing. Can I ask you a little bit about what the next stage of your research looks like?
Several different projects on the go. So with my PhD, first of all, with the development of psychosocial interventions for retinoblastoma, I've already got plans, sourcing some funding at the moment to actually work with young people to develop and then test the intervention based on the data that we've collected as part of the PhD. I'm very keen to have been all throughout the whole PhD and all of the research I do to co-produce with young people, because I genuinely believe they are the experts in their condition.
Absolutely.
And I like to think that they can bring that to some of the skills that I have through my training to develop something really meaningful. I also am involved in a project called Cancer, Fertility and Me, which is a research project between Leeds Beckett University and the University of Edinburgh, and they've already created a wonderful decision aid for young women who have got cancer regarding making the right decision for them around their fertility preservation. And we're now doing a project for young men, thinking about what options a young man has when they're diagnosed with cancer regarding whether he wants to take steps to preserve his fertility, if he has that available to him in the context of his diagnosis, and what those different options mean. So that's a really exciting piece of work, and one that will lead to the development of a new resource which hopefully will be rolled out across different paediatric oncology settings.
Thank you so much for joining us. If people want to find out more about the work that Nicola's doing or more general research in this field, we will share some useful resources in the show notes. And then Nicola, I'd like to end, as we end every podcast, by asking you to share a book recommendation.
So a book that I have read recently is called A Heart That Works, and it's by Rob Delaney, who some people might have seen on TV in various capacities, and it's a memoir about his son Henry's life and death experiences when he was diagnosed and sadly died from a brain tumour when he was 2.5. So it's obviously a really emotive read, but I think it also gives a real insight into a parent's experience and a family's experience of childhood cancer, and I think it's an insight that we don't usually get, and one that is very powerful, so I would definitely recommend.
Thank you so much, Nicola. It has been such a joy.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the Peds Hub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch. Thanks for listening.